Thank you for having me. Today I'll be discussing hepatitis B global burden of disease results for Global Burden of Disease 2019. For some context, for those who are less familiar, the global burden of disease is a systematic scientific effort to quantify the comparative magnitude of health loss due to diseases, injuries, and risk factors by age, sex, and location for specific points in time, and is the largest and most comprehensive effort to date to measure epidemiological levels and trends worldwide. We make estimates for 369 diseases and injuries, for 204 countries and territories, for both sexes separately and together, 23 age groups, and every year from 1990 through the most recent year of estimation of 2019. We strive to make our estimates internally consistent and to standardize our approaches across diseases and for different data sources within diseases so that we can truly make comparisons of like versus like. And we produce our work iteratively with annual or every couple of year updates to ensure that new data and methodological innovations are incorporated. And we do our work as a core team of several hundred employees and a larger team of more than 4,000 collaborators from 147 countries and territories, including more than 600 with interest and expertise in hepatitis and more than 300 with particular interest in cirrhosis. Our modeling approach for hepatitis B burden estimation involves a number of different statistical models, plus some additional modeling assumptions and steps, which I will not detail here. I'm happy to discuss with anyone interested after the talk, but I do want to preserve my time to go over some of the results. I'll simply point out that we have statistical models that synthesize primary data sources for hepatitis B surface antigen seroprevalence, hepatitis B 3-dose vaccine coverage in infants, the prevalence of cirrhosis, both total and decompensated, and mortality due to cirrhosis, which are models that don't take into account etiology, as well as models of the proportions of cirrhosis that are due to hepatitis B and other etiologies. We have models of statistical models of liver cancer mortality, again without regard to etiology, models of the mortality to incidence ratios for primary liver cancer of any etiology, and proportion models to divvy out that mortality and incidence according to etiology. And then statistical models of acute viral hepatitis, both across all viral types and specific to A, B, C, and D, E, which are then fit to an envelope of all virus types. Our modeling approach starts with a counterfactual model of hepatitis B surface antigen prevalence based on data from cohorts not exposed to mass vaccination programs, and then we subtract off cases averted by hepatitis B vaccine coverage. We apply the proportions that we model to determine what proportion of cirrhosis mortality and prevalence is attributable to hepatitis B. Similarly for liver cancer. And then once we have estimates for cirrhosis, liver cancer, and acute hepatitis due to hepatitis B, we sum the burden of the mortality, years of life lost to premature mortality, and years lived with disability. I won't go into details of how we estimate years lived with disability because of our focus today on elimination targets, but again, that's an area where I would love to discuss with interested parties after the talk. The elimination targets I will be discussing today in comparison to our estimates of hepatitis B burden are interim targets for 2020 described in the World Health Organization Global Health Sector Strategy on Viral Hepatitis, which include a 10% reduction in deaths by 2020 relative to the baseline in 2015, and a 30% reduction in new cases, for which a very common proxy measure is a less than 1% HBsAg seroprevalence in children under 5. The next set of targets are also from the Global Health Sector Strategy, but targets for 2030 of 65% reduction in deaths and 95% reduction in new cases. Again, where the proxy often used is in terms of hepatitis B surface antigen prevalence in children under 5, with that target being 0.1% by 2030. And then finally, the more recent provisional targets proposed as part of the World Health Organization interim guidance for country validation of viral hepatitis elimination earlier this year, where a proposed target is mortality rate of less than 4 per 100,000 person years as an absolute target rather than relative to a baseline in 2015. I won't describe all of the data inputs and statistical approaches in our pipeline, again, hoping to focus on results, but I will show here the coverage of data that we have. So these are serosurveys for hepatitis B surface antigen in our database, either extracted from peer-reviewed publications or the gray literature. Every country with blue has at least some serosurveys. In gray, we don't have any primary data for this indicator. Estimates are produced for every location, however, using our disease modeling meta-regression tool, which is a Bayesian meta-regression approach developed for global burden of disease estimation that uses regional models as priors for country-specific estimates, where local data update priors from the region. And this tool can incorporate various covariates, an important one for HBsAg being hepatitis B vaccination coverage. Here I'm showing data coverage on the left for mortality due to cirrhosis of any etiology from vital registration of vertebral autopsy data. Again, we produce estimates using a modeling technique that incorporates predictive covariates and also spatiotemporal smoothing techniques. On the right-hand side, I'm showing the data coverage for our models of what proportion of cirrhosis is due to hepatitis B, using data extracted from cirrhosis case series, and again, using our DisMeta-MR model and predictive covariates. And then here I'm showing the data coverage for our models of the total prevalence of cirrhosis without regard to etiology, and the prevalence of decompensated cirrhosis, again, without regard to etiology. I'll move on now to some of our results. First, HBV-related mortality rate. So the sum of cirrhosis, liver cancer, and acute hepatitis, all due to hepatitis B. In the upper left, I show the mortality rate for all ages and both sexes combined in all of the 204 countries and territories in our estimation framework, with blue representing mortality rates ranging of less than 2, and then a scale that goes up to the red countries have mortality rates, even into 2019, between 10 and 30 per 100,000. In the bottom right, we've grouped countries according to their sociodemographic index. The sociodemographic index is a composite measure of income, education, and fertility in women under 25. And this index we've assigned to every country and then divided them into quintiles to show the progress made between 1990 and 2019 with regard to HBV-related mortality according to level of sociodemographic index. You can see that the greatest progress has been made in the middle SDI, high middle, low, all have good progress. And then as a progression over time, our high SDI countries show less change, but also lower absolute rates to start with. The vertical dashed line is for the baseline for the elimination targets in 2015. Just want to briefly look at age patterns for mortality. over time. So here we're again looking at death rates per 100,000, just as in the last slide. But rather than for all ages combined, we've divided these out. These are the age-specific death rates. And blue shows the death rate in 1990, red shows the death rate in 2015, and green in 2019. We see that every age group experienced improvements in HBV-related mortality over the period of our estimation, and it's small improvements in mortality rates between 2015 and 2019. But of course, we also are reminded here of the pattern, the age pattern in mortality for HBV. Although acquired at young ages, the disease plays out as premature mortality more in middle age and older ages. And this raises the point that results and progress look really different depending on the metric chosen, and in part due to this age pattern of disease. Here I'm showing the change in mortality rate, in the all-age mortality rate, between 1990 and 2019, when we measure mortality rate for all ages combined. And from the top, at the top, we're looking at the global change, and then below that, looking at each WHO region. And we see that when we look at mortality rates over time from 1990, almost every region had a net negative change in HBV-related mortality, with the exception of the Southeast Asia region. When we look at age-standardized death rates, where we've taken our age-specific mortality rate estimates and then treated every country as if it had the global age pattern rather than their own population age distribution, we then see even more impressive progress in mortality rate over time, reflecting the fact that some countries and regions are have a greater challenge in reducing HBV-related mortality due to the age of their population and the age of their chronic cases of HBV, as younger cases age into the age groups where mortality is higher. Another demographic force that we need to consider as well is population growth. If we look here on the left at death counts, we see that only the Western Pacific region had a net negative change in HBV-related deaths between 1990 and 2019 by our estimates, and every other country had an increase in deaths, or every other region had an increase in deaths because of the combination of aging and here population growth as well. If we then focus in on the period from 2015 to 2019, the time since the establishment of elimination targets, we see that progress is best when viewed as an age-standardized death rate, more of a mixed picture if seen on the far right, more of a mixed picture if we look at all age death rates over time. And again, not a whole lot of progress if we look at things in terms of death counts, where we're fighting against population growth. Here we see a vertical green line at the 10% mark, which would demonstrate achieving the 2020 interim target, which no region meets. Here, I'm looking at the two different mortality targets that we described on an earlier slide. The death impact target of a reduction in 10%, reduction of 10% in deaths between 2015 and 2020. And when we look by WHO region, we see that where red represents the number of countries within the region that have not met the target as of 2019, and green represents the number of countries within the region that have met the target, we see very few countries in any region meeting the 10% interim target in reduction in deaths. But when we view things in terms of mortality rate of less than 4 per 100,000, we see a large number of countries already meeting the 2030 target by 2019. But with great disparities across regions, with many or even most countries already meeting the target in 2019 in region of the Americas, European region, Eastern Mediterranean region, a good chunk of countries as well, but far fewer countries meeting that target in the Western Pacific, Southeast Asia, or African regions. I'm going to turn my attention now to the new case targets as expressed as proxy targets of hepatitis B surface antigen seroprevalence in children under 5. The upper left again shows results for 2019, with blue being the lowest prevalence countries and red the highest, again in children under 5. And the bottom right shows progress over time from 1990 to 2019. Vertical dashed line represents the 2015 baseline for elimination targets, and the colors represent countries by different levels of sociodemographic index. If we translate these into countries meeting or not meeting targets, on the left-hand side, we see countries that met the target of less than 1% prevalence in children under 5 as of 2019. And on the right, we see countries that already met the target of less than 0.1% HBsAg seroprevalence in children under 5 as of 2019. So many more countries meeting targets for new cases and prevalence in children under 5 than for mortality. So conclusions from our findings: we see great progress in reducing HBV infection in children under 5, who are new cases of chronic disease. We see progress in reducing HBV-related mortality when viewed as an age-standardized rate, but progress is more or less challenging depending on the metric chosen, because countries are facing different age distributions of their cases and different amounts of population growth. We also see disparities across the globe that demonstrate the need to target interventions, with some parts of the world already meeting targets for 2030 and other parts of the globe missing 2020 interim targets and not in a good position to achieve 2030 targets. Thank you.